problems with getting the data out in these interfaces?
Yes, we have, of course, a lot of problems with the EMR vendors, but I think now we already have the momentum. So many vendors have integrated that system that there are, I think, only 2 small vendors who have done that. And then also when the vendors, they compete with each other, and providers consider decision support as a very good feature. So it means that they also compete in who implements this best. So I think now we have reached the point when it will come the standard.
And can I ask you one more question? The patient adds data to the database that the general practitioner extract data from.
Yeah, at the moment there is a national archive coming for professional data, but not for data that patients will enter. There is a project that there should also be a national repository for data that patients can enter, and then we should merge that data so that both professional enter and patient enter data would be available at the same time. And I think this is the main goal which we try to accomplish, at least in some parts of Finland, within 1 year.
I'm just wondering, because we've had, people wanting to do things that could go in through the data capture module. They could go back into the general practice journaling system.
Yeah.
And general practice were asked about this. Would you like patients to be able to record things and get it back into a system? And the answer is no. Because if patients are doing that in ways which you are not reviewing all the time, then you may get information there that you need to react on as a GP, as a list GP. So they would rather have the data as emails, but not a lot of data that comes in, from sources that are miscellaneous, and that may be later difficult. When should the GP have reacted? Do you have this problem?
Well, I would say that we do not yet have this problem. I think if you ask Finnish GPs, they would very much like people to record their blood pressures and their weight, so that the most recent measurements would be available. Also, if before the consultations they could fill in sort of form or questionnaire where we could already record some things that would facilitate the consultation. Yes, doctors are afraid. I think they are most afraid of emails coming in from all patients. So were also the doctors in Kaiser Permanente. They were afraid before this My Health Space was established. But after a few months of using it, they realized that it did not increase their workload, and it even decreased their workload because there were fewer face-to-face consultations. And I think nobody resists this system now at Kaiser, and I'm quite confident that the same will happen in Finland.
We know email consultations. We have that. We've had it for years. So that's not it.
So we use these printed prescriptions in the end because we thought we only do this in Romania. We've had the e-prescription system since January 1st this year. What I wanted to ask was, I saw there a summary shared health record, the summary of the health record shared with others.
Yes.
I was wondering, is that like some information in an emergency situation? So if the patient is in an emergency situation, is that the information that the paramedics or the A&E unit would see?
Well, that's the idea. That's one of the ideas. And it's not just for emergencies, but the idea is that when a patient ends up at another clinic, or they're on holidays, or they've had an emergency, or they're sort of, if you look at some of the ads for the PCEHR in Australia, they'll talk about when a patient arrives unconscious at the emergency department, nobody knows anything, and then somehow a family member says, oh well, check the shared electronic health record, and then of course the clinicians know everything and miraculously save the patient. That's the idea behind it. How true this is, as I say, we can go by the extensive evaluation of the UK program, which found, in fact, that when you weigh up the rare benefit that you might get from it, the bigger problem is that if the data is not of good quality, clinicians tend not to trust it. And when you don't have the trust in that system, they tend not to use it. And then, of course, it unravels because it might happen automatically, like our e-prescriptions are happening, but nobody actually wants to look at it because they don't trust it. So this is a bit of a problem with health records generally. I think that sometimes they are reminders for the doctor who normally looks after the patient, but it's not necessarily something that's totally trusted by another doctor in another site.
One of the problems with the UK that Chris Greenlaw found was that the people did not know about the system, so therefore they can use it. That's the information.
Yes, well, yeah, I mean, it's still early days in Australia. We'll see how far it goes and whether it's being advertised and promoted by the government, but they've fallen very much behind in terms of just registration of patients. So probably right, it's still a fairly well-kept secret. Any other questions?
One of the small things that you mentioned there was in relation to searches and clinical queries, and you seem to have a preference for the Medline's PubMed over Google. Do you find them practical in a clinical setting?
No, it was the other way around. Google was the favourite one.
Yeah, that's, but personally, it seemed you were saying that.
Yeah, that's the, when they've done surveys of doctors and GPs in Australia, Google is the favourite search engine.
Well, would you think that is, Google should be the gold standard search engine, or?
No, I don't think it should be. I mean,
But then is the Medlines and PubMed practical in a GP setting?
It may, that one may not be, but you can learn how to use some databases, particularly guideline databases, and therapeutic guidelines, for example, are a series of books on specific topics such as dermatology, gastroenterology, etc., which are reasonably popular, and you can look at the bottom line of the therapeutic guideline for a specific topic within consultation. If you don't know what the second line or third line antibiotic is for a particular condition, you can look it up fairly quickly. So I think, with the upskilled GPs, they can go more to evidence sources. With Google, I mean, obviously the risk is that if you don't recognise what you've found in terms of the credibility of the authorship, but you've just found a page, then you don't know if it's believable or not. And so I think that there is still a degree of upskilling required, even though Google is sometimes very useful.
We use a data extraction tool called CAT, Clinical Audit Tool, and it's PEN. And so what we can do with our practice is pull out anyone that's on more than 5 medications and decide then that these patients need a home medication review by a pharmacist, or we can see who's not fully immunised, and particularly in children. So I think from just the private practice using a clinical audit tool that extracts data from the clinical software, that's very powerful to be able to find out what areas of your general practice that you're overlooking in caring for your patients.